everybody. We are going to open our informational meeting as we will go through the agenda items, but we will not take action today. But we have some wonderful opportunities for discussion around population health today and a couple of different proclamations. So I am sad to report that Candace has asked that she be removed from our wonderful group, as she's got a lot of things happening in work right now and is afraid that she can't make the time commitment. So we will be looking for a psychologist position, and be thinking in terms, if you know of those that you would encourage to apply, and the application period will be open. And then we also have consumer advocate positions as well. Right. So moving forward, Jan, let's talk about top health. Did everyone receive the email? Did you send, did everybody get the email about the health?
They should have gotten, yeah, the whole how the Human Services Board should have gotten
Yes.
county health rankings.
Yes.
They came out on the 15th.
They were embargoed, but we had a chance to look at them before.
Thank you all for allowing us time on your agenda today. We do want to talk to you about the county health rankings and kind of give you an overview of what we found this year. And just a reminder that our county health rankings are kind of a snapshot of the health of our community today and somewhat of a predictor of what our health of our community will be in the future. I think you'll find our report, or you may have found already if you've taken time to look at it, very comprehensive. And I think you'll also be able this year to really understand the valuable partnerships that are in play in our community around community health. Those are really evident in our overview this year. So as you all know, assessing the health of the community is an essential public health function. It's mandated that we provide that service in our community. And I will tell you that we are fortunate in our community in that we experience and nurture a very valuable partnership with our community health assessment and improvement process. So you're going to hear from us today about the state of the county health report as well as the county health rankings. And that state of the county health report has gone to our State Division of Public Health and has been approved. So it will become public after we allow you all the opportunity to review that. I do want to acknowledge that our partnership with NAHAC through a fiscal contract makes this work very strong, and that we have experienced some growth in that partnership. NAHAC has allowed us an additional resource for our team this year, which Zoe and Evan will be talking a little bit about. But that added resource has really allowed growth in that program, and our team is stronger, and ultimately our work is better. So without further ado, because you don't want to hear any more from me, I'm sure, I'm going to introduce you Zoe and Poku. Zoe is our Community Health Assessment and Improvement Coordinator, works for HHS, and she's part of this strong Community Health Assessment and Improvement team that we have working in our community. And along with Evan Richardson from NAHAC, who is the newest addition to our team, that they will be presenting this information for you today. I just want to point out that the expertise and high-level vision that they have for this work is creating amazing change in our community and the way we do this work on the ground. So we're fortunate to have both of them at the table, and without further ado, I'll invite Zoe up here for you. Thank you.
Hi, good afternoon. So greetings, and thank you for giving me the honor to be able to present to you today the community health programming that we have been able to participate in within this last year. This afternoon, I'll be presenting what we're calling the year in review. So in addition to the county health rankings and the state of the county report, I'll also want to just go through what the year looked like. As Jan mentioned, so many of the successes that we've had this year have come from really strong and really intentional partners and partnerships. And so I'd like to just recap some of the work that we've been able to either help push forward, uplift, or advance in some way. So as Jen mentioned, I have the pleasure of being joined today by Evan Richardson, and she is the Quality Improvement and Patient Safety Director at MAHEC. As Evan is not only newest to our CHIP team, she's also the newest member on the CHIP Leadership Board. And so without further ado, I'd like to have Evan come up and just introduce herself to you a little bit more formally.
So it's an honor to be here, looking at the familiar face of Sonia. Nice to see you. And I know many of you around the room, and some of you I don't. I've lived in Asheville for 20 years, and I'm a nurse midwife. I show up to the work that I do primarily from that place. I've had the benefit of working both with New Dawn Midwifery and Planned Parenthood here locally, and have been doing quality improvement work for the last 8 years or so. Prior to that, my midwifery work was in the Bronx, in New York City, and inner city Baltimore. And so I even came into being a nurse midwife as being a lay midwife. And so I have this unique perspective on where health happens. I also was raised in West Virginia, lucky in honor of my mother, who actually died in October, and I just keep kind of wanting to raise her up. Had a 40-year career, both at a state level and a national level, as a rural health expert in healthcare policy and advocacy. And my mother was known, what I learned from stories, to open up national level meetings, always saying, let us be reminded who we are really here for. And so we just want to raise that up today. And I guess the other piece is I'm new to the team. I'm really grateful. Frank was one of the people that helped pull me into this, and Dr. Heck as well. Deanna Lamont and Terry March, that many of you know, had a conflict and so aren't able to be here today, but I cannot, I'm stepping up in for them on some level, and I'm also acknowledging all of the work that's happening in our community. That even though I'm speaking words, I'm really not the representative, so to speak. So, yeah.
So to begin, just to give you an introduction, an overview of who we are on our team, we have Jen Shepard, who's our Public Health Director. We also have Frank Casablanco, who is the Director of Regional Services for MAHEC, Sonia Grech from Mission Health, and she's the Senior Vice President of Patient Safety and Behavioral Health, as well as leading a lot of the efforts within community benefits. Evan Richardson, and then providing technical assistance and consulting, that's Terry March, and she's a health improvement specialist at MAHEC. Deanna Lamont, also a health improvement specialist. And Terry and Deanna are really the boots on the ground who provide a lot of the subject matter expertise and a lot of the partner engagement and capacity development for diabetes, infant mortality, and also our work around opioids, or excuse me, substance abuse, and also within intimate partner violence. Also new to the team is Rachel Long, and she's an independent consultant, and she's serving as an epidemiologist. And so as we are entering a community health assessment year, it's really key to be able to have her expertise in order to provide that high level, for the macro and the metadata, and also that micro level for us to be able to see, or at least have an expert who knows some patterns that we may be able to pull out once we actually get our data set back in the midsummer. So the goal of this presentation today is to provide you a summary update on not only where we've been throughout the year, but also to demonstrate to you the strength of this partnership between Buncombe County Health and Human Services and MAHEC. Also, as a matter of meeting some accreditation benchmarks, today we'll have a review and also discuss some program outcomes and data utilization. We'll share ways that we can better serve populations that are at risk, vulnerable, or underserved. And then also, we hope that this offers you some guidance on how to apply, or at least help us advance some high-impact policy and systems levels interventions. So where have we been? A year ago, in April, we welcomed Mia Birdsong. And some of you may remember that she's posed that the story of poverty that we all have maybe tied to is not true. And that as we look at community health, or any community development for that matter, the solutions that we're looking for, the community already has. So when she was here, she told a story about that at every evening she asked her young girls these 3 questions. How were you brave? How did you fail? And how did you show love? I find these really compelling, and also at a very kind of technical level, they remind me of our quality improvement model that we use called results-based accountability, and that also has 3 questions. So for how are you brave, we ask how much did you do? For how did you fail, we ask is anyone better off? And for how did you show love? Excuse me. So for how did you fail, we ask is anyone better off? And how did you fail? Pause. I hope you understand that all of this really helps us ask better questions, but also able to engage those grassroots energies into ensuring that we have better outcomes. We also had a busy summer. So to begin, we had a resource day out at the Big Ivy. And so this was a great opportunity for the community engagement team, for our sheriff's department, as well as our community connectors, all of our HHS divisions, to really be able to provide some overview of the resources that are available to our Northwest community that is in a rural setting. So beautiful out there. I had no idea how close it is in terms of its proximity to the National Forest. But while we were out there, we did take the opportunity to survey the community's experience of the services that we're providing, and they gave us some really important feedback. I think one of the most frequent responses was that if there's any way that we can adjust for them to be better connected to services, is adjusting our early hours, so perhaps services before opening hours, so 7 a.m. to 7 p.m. So if we can extend on the ends by 2 hours, and then also they would welcome weekend hours. And so if weekend hours were up to 2 p.m., that's a level that they feel as though they were able to feel much more satisfied about what we do to ensure better economic services or any of the resources that we have through the divisions. Stacy Wood, our public information officer, and I also participated as a County of Health community through Robert Wood Johnson in the Project Connect. And Project Connect is an initiative that Robert Wood Johnson provides for communities to connect with their legislators. So in addition to getting some training around advocacy for government officials, we were able to put together a package to tell the story around an issue, and we chose opioids. So we were able to meet with our federal House and senators, as well as their staff, and tell them about this mountain of opioids that we have. We made some asks. We shared some information on the programs that we have here, how we're really getting ahead of the curve. And I'm actually pleased to say that despite a lot of the hurdles that we met, this first quarter report from the state shows that within the first quarter we had 32 fatalities last year, and there was 8 this year. So now that might just be some seasonal, but I think that it shows some progress. One thing that I am alarmed about is that last year at this time we had no fatalities for African Americans, but this time they're accounting for 9%. So, but that's really something that I'll speak to later about ways that we're actually expanding to have an equity conversation around opioids. We also, because of the opioids response, worked with the Trauma Intervention Program, which is a first aid around big stressors in life. So the TIP program trains civilians to really be able to support first responders, and they're there within the first 72 hours to help folks kind of navigate if they've had a big stress. So could it be a car wreck, could it be a house fire, could it be an overdose, as has been experienced by folks in Pisgah View or in Bartlett Arms. These are the communities that we were really identifying, because imagine what it must be like for children that are going to school to be able to see someone who has had an overdose from the night before in the yard. So those are things that are really impacting. So it's not only about what's the trauma that the neighbors or that the family that's lost that individual, but what does the trauma do in terms of creating adverse community environments. And then there's ABIPA. I know most of you all are fans. ABIPA is the Buncombe Institute for Parity Achievement. They're doing great work in terms of advancing or supporting our community health outreach, whether it's around preconception health, but specifically around their work in diabetes. And PRAISE engages congregations in being able to advance behavioral and environmental changes. And so in the summertime, they honor through a gala and celebration all of the congregations that they've been connected to really recognize them, because we all know that there's storming, norming, forming, but there's also a very important to convene. And so sometimes it is good to celebrate your victories in order to keep that spirit and keep that engagement going. So in the autumn, again, the big pill, still here. So with the community engagement team, MAHEC, Dr. Fagan presented to a group of African American pastors not only an overview of what opioid response is looking like in the region and all the data, but we also created a presentation for him on how can Asheville or Buncombe County not be the next Cuyahoga County. Cuyahoga County is where Cleveland is based out of, and they're seeing pretty much the worst when it comes to opioids around the African Americans. Cuyahoga County is where we're seeing it turn, where it's like HIV in many ways, a disease that did have a high racial disparity, and so through this presentation we're able to say, hey, what we learned from, there's different things that we've been able to get from Cleveland, whether it's rock and roll, whether it's the best NBA player, LeBron James, or rock and roll or Prince. So there's lots that's good that's come out of there. But right now, we've got this other trend, which is African American opioid epidemic is starting to emerge. It's emerging because there's a different way that African Americans often are initiated into opioids. So we've had clinical bias where they may not have been able to be prescribed, but also there's a difference in that for those that are recreationally engaging in it, it's usually through what are called speedballs and cocaine. So being able to show that it may not even be true in the data that we're seeing, because when first responders come, or once the hospital does their evaluation, they might see the cocaine and it might be more prominent. So there's ways that we really need to see how do we ensure those numbers, those hidden numbers can emerge, and that we ensure that our African American community feels as engaged, and we can really address the policy stigmas and impact of other drug epidemics so that they can feel attached to this as well. We also were able to host last summer the Southeastern ACEs Summit, and so many of our partners in this resiliency effort presented academic papers, including Keenan Lake of the community engagement team. He presented his work that he's doing through My Daddy Taught Me That, where he's doing a lot of development, educational development, skills building with young African American teens. And then our commissioners, they supported our efforts around opioids by doing some outreach in some of our more suburban and rural areas. So we had a town hall in Black Mountain, also had a town hall in Fairview. So it's really great to have leadership that can listen to the data when we share it and can help uplift all of the peer-to-peer based conversations that we've been having. So that it's always nice to have that support to elevate any of these poor outcomes that we're having. So now I will give the floor to Evan, who will present our county health rankings. So if we do have time, I'd like for anyone who did happen to miss the WLOS video, we did actually get coverage of the county health rankings this year. It's a little small clip, but for purposes of ensuring that we can manage technology, we'll probably wait till the end.
That's a great one. That's awesome. That actually stands for many things. So I think Jan referenced that the county health rankings, which come out every year, that's a joint project of Robert Wood Johnson and the University of Wisconsin and Madison, is a really great snapshot of how are we doing right now, the health of our county today, and based on certain measures, what do we expect our health to be like in the future. One of the things, traditionally, it also gives us the opportunity to see how Buncombe County compares to other counties in the state and other high-performing communities in the nation. And I think based on the fact that there's been such a commitment over the last 5+ years nationally to start collecting data that allows us to see trends in terms of potential disparities along racial and ethnic lines. This is the first year, believe it or not, it's kind of stunning, but it's true, that we're actually able to drill down on some of the measures by race and ethnicity, which is important information. And I wanted to just sort of point out this is a highlight of the way in which we're working differently. So I stepped in October. This was all done before me, so it was a great inheritance. Revisioning, and so Sonny's at the table, Frank's at the table, Jan's at the table, CHIP leadership really looking at changing the role of CHIP a little bit. So rather than having health improvement specialists who are coming in and doing a lot of the convening, really looking like the leaders, recognizing the assets and the strengths that are present in our community, and just kind of flip it a little bit. And so that intentionally the work of CHIP is to kind of speaking along the lines of Ian's birdsong, identify where there is already resilience and strength and support that and raise and kind of give lift to it. And so we have some partners who have a hard time identifying how do they fit into the larger social determinant of health. That one of the pieces we're trying to do is work with the CHIP Advisory Board to get every member to understand, regardless of whether the priority is something that your organization directly has a link to, we all need to be at the table in order to improve community health. And so we work together and use the wonderful communications team at the county, as well as communication resources at MidTech, to write a really great press release that now has been picked up two ways. So this is evidence, and actually to be able to connect up Bob Wagner from Mountain True to presence the role of the work that's been happening in connecting people to the natural environment and air quality. That actually is fundamental to our community health, and so he got to presence that, which is awesome. And then next week we're expecting a Mountain Express article that will specifically highlight some of the work that Dr. Nan Crane and AHIC is doing around preconception health and the community health ranking. So we see that as a win in terms of our working relationship. So let's talk about our health today. And so we're going to focus first on what we can celebrate. And so Buncombe County is number 14 across the state in terms of overall health outcomes. And that specifically speaks to current premature death rates and the number of days that residents reported experiencing poor health. And so we've seen there are lots of little things that are coming into that where we're seeing some positive and negative, but overall we're doing well there. So it's something to actually feel good about and celebrate. And again, going back to the fact that there are lots of little ways in which community partners contribute to that, we have so many people to thank for that. Overall health factors. Now we're starting to take a look at the trends that speak to what our health is going to look like in the future. So overall health factors, we are number 3, and that specifically is a combination of a number of things. So when it comes to clinical care, how great are our care services? We are number 3 out of the state, which is pretty remarkable. Social and economic factors, we're at number 8. And then in terms of individual health behaviors, tobacco use, intoxicated driving, lots of different things that contribute to health. We've gone from 7 last year to number 5. So we're actually moving we're moving the target, we're moving the needle a little bit in those areas. And again, it could only be done by many, many people working towards it. Additionally, in terms of tomorrow, physical environment. So we had a 20-point jump. So last year we were number 49, and this year, last year we were number 69, and this year the ranking shows us at 49. I just want to point out that this relates to things like air and water quality, housing, and then things like the percent of population who drives alone to work. And then, of course, air quality increased slightly to 81%, and we all know that when we're talking about air quality, we're talking about how it shows up: asthma, chronic bronchitis, and other pulmonary conditions. So this is stuff that we can all celebrate. So despite the fact that we have a lot to celebrate, we also want to make sure that we are keenly aware of the work that we still have to do. And so if we think about our health for the future, the fact that 1 in 4 children in our community live in poverty, we know we have really important work to do. In addition, premature deaths. So I just raised it up because we're doing really well there. This particular measure from Robert Wood Johnson does not include overdose deaths. And so we know that if we were to throw in the numbers related to overdose death, that we would actually not be doing well in this measure. And I think Joe already highlighted that last year, I think so we're ahead of the curve right now. So if you look at the data for 2018, this time last year we had 32 overdose deaths. To date we have 12. But what's remarkable is this time last year we had 0 African American deaths related to drug overdose. And we're about 9% of the drug overdose deaths in the county to date right now are among individuals identified as African American. So we've got something that we really need to be aware of. And then lastly, sexually transmitted infections. We've had a 33% increase in STD rates over the past year. I want to just raise up and highlight work that's been done by Mountain Zion and Project NAP, which lay health workers that are really working with population women and young women around reproductive justice, as well as the county's Show Your Love campaign, and of course the Family Planning Clinic doing a lot of advertising. Yes.
Evan, do we have any data on that increase in STDs and where that's falling? And is that distributed over one group or another, age-wise, race? Any breakdown on that? That seems like a jerk.
Yeah, but actually that's
So this data, we have to remember, what is in the 2018 county health rankings is actually data, when I'm speaking to STD, it's data from 2016,
Okay.
right? Because we don't even have final numbers for 2017 yet from the state. And when I drill into it, they're actually just looking at chlamydia. That's what STIs is meaning there, it's the chlamydia rate. And we are drilling into that in terms of trying to get the demographic information. We don't always have easy access to it because we get those reports when we shuffle them to the state. So the state, I've been working pretty closely with them to get that sort of breakdown. I would say racial disparity is huge in all our STDs, definitely. Seeing disparate more in African American population and young age groups. When I have my communicable disease incident report and June meeting, we're going to dig into that a little further. But
So over the course of several years,
Yeah.
or whatever else here, have you then, has this then allowed you an opportunity to refocus resources and/or project types into that manner? I mean,
so, yeah, I mean, I think that a couple years ago, we did a short group. This is back in the days when Keenan and Rashida were still social workers and just starting their community engagement. We tried to do some work within the Piscoview community because they were in there. And then with transitions, that kind of fell back. I think we're doing more testing in the community because we're getting into the jails. We're doing outreach with WinCap, which may increase our numbers, right? Because if you're testing more, if you're finding more, it's going to go up. And we are, as we're gathering this data as we speak from the state, we're planning our next sort of attack, I guess we would say, on like how we're going to tackle this huge problem.
thank you for that
Yeah.
information.
Yeah, and that actually highlights, so when we talk about taking a quality improvement approach to community health and quality improvement, I always talk about where can you put 80% of your effort, 20% of your effort and get 80% of the gain. And so we're talking about some important through lines that regardless of what the priority is, what are these things that we need to continue to address and focus on that we're really going to make a huge difference in terms of overall community health improvement. And so one of them is health equity, racial disparities, structural racism. So when we talk about STD rates, reproductive justice, trust in the healthcare system is a huge piece of a barrier. And so I just want to kind of, we are trying to give touch points throughout this entire presentation today, just to let you know how we are beginning to really intentionally focus on racial equity throughout all of the community health work. Okay, let's see. This is, so of course, we know, I think if Dr. Heck were here, he would say, really proud that we have this incredible clinical community, but that's not enough. And without really addressing social determinants of health, well, we're not going to get anywhere. And so just wanted to point out that this is where it's really exciting that the community health improvement work and the health rankings align really well with the county's sustainability plan, because we are seeing the ability to work in hand-in-hand with the engagement team along the work that's happening in the county is making a huge difference. So here's some of the highlights of some of the work that's been going on to address some of the social determinants of health. Isaac Coleman grants, which were really addressed the ability to create pipelines for stronger economic and educational opportunities in terms of vulnerable communities. The Community Connection STEP program, where we're taking the ability of recipients of SNAP, or I don't know how many of you, I realize that I've been out of the community health world enough to not realize that SNAP means food stamps, so in case there are any of you that don't know that as well, I'm going to share with you that partnering with AV Tech to actually provide some light case management and connections that help folks with food stamps to be successful in graduating from programs and then getting placed in jobs. And then lastly, Project Cara, which is a MAHEC clinical service, a clinic within our women's OB/GYN specialists. We're specifically focused on women with substance use disorder who are pregnant. And I think there's so much we can speak to the gains. One of the things I think stands out the most is that one of the measures that they're using as their success is whether women self-disclose their use, and that they're actually getting, they've created an environment that is trustworthy and safe enough that women are doing that, which is a huge piece.
So on to the county health rankings. So this year, the county health rankings, it was the first official year that all counties submitted it electronically. So that RBA model that I've mentioned before, that's something that is implemented within what is called a scorecard, where you have your data and then you tell the story behind the curve, which is really what type of programming or what type of interventions did you apply. And then you also are able to have your tables for actually how is the needle moving. So how much did we do? How well did we do it? And is anyone better off? Yes. Thank you. So the SOJ was submitted and we did get it approved on March 20th. And we were able to get the feedback, well done. So we'll probably be able to have some more feedback on what we can do that we may be able to follow up within our community health assessment next year. So within compiling our SOJ, we use the following resources: the Western North Carolina Healthy Impact Book, the 2017 County Health Data Book, as well as the WNC Healthy Impact Data Workbook, and that was updated on June 2017, as well as work group performance data. And then we also had contributions from our CHIP advisory and community partners for some secondary level data. So our priorities are reducing chronic disease, or with a focus on diabetes, infant mortality, and also addressing the racial disparity in our birth outcomes, and intimate partner violence, which we've been pivoting to a focus on prevention, and then also ensuring that the Family Justice Center, who really are the key drivers in this work, are able to uplift it. And we've seen that the best way that we can really advance any efforts on IPV is to ensure that the Family Justice Center can take the lead. So for diabetes, again, diabetes nationally, at the state and at the county level, in general is down. However, when we see that disparity rate along race, it continues to be stagnant and not really progressing very well. So we've had a slight downturn, but again, it's really not enough. So 3.4% racial disparity. African Americans are 3.4 more times likely to die from complications of diabetes. So we consider this as something that's unacceptable. As we pivoted how we're doing our work within the CHIP advisory, we're considering diabetes, one of the others, what we are calling a canary in the coal mine. World Health Organization, CDC usually will use infant mortality, so we're deciding so that we can look at everyone and not those that may actually be part of, actually pregnant, but in general, let's also consider that the canary to also be diabetes for how well are we doing generally across all races.
So going back to that slide, you say African Americans are 3.4 times as likely to die from what is diabetes, or did I see 3.4% racial disparity?
They're 3.4 times more likely, so it's the mortality disparity.
That would be 340% if it was 3.4 times more likely.
Yeah.
3.4% is a relatively small difference.
So you have a percentage.
Oh, I have a percentage. So that's a typo, excuse me.
It's an X.
And I can just add to that from publicly available data, when we geomap down to zip code, the census tract that we are in right now actually shows a 9 times disparity, so that individuals, African Americans who are living in this area, is a larger census tract in Asheville, are 9 times.
I mean, I agree, and I understand that number there. It just threw me off.
Yeah,
because of
I'm like,
the
well,
percentage.
I'm doing so
Right,
bad.
there we go.
All right.
Yes.
Appreciate the clarity. So working with us to address disparities, this is a snapshot of our partners. So to date, we've been able to engage over 30 organizations to address diabetes. So whether it's for clinical services, food system support, or physical activity and engagement. Our 2 most prominent action plans and interventions that we're using are the results-based accountability, and this was something that we chose within the offered intervention options that the state offered when we did our community health assessment, as well as the National Diabetes Prevention Program. And the YMCA, in partnership with ABIPA, has really been carrying that through their Managing Type 2. Managing Type 2 is a program that cohorts can go through for, depending from either 6 to 12 months and sometimes 9-month program, where they're able to work through a peer cohort to learn how to eat better, even do shopping trips to better navigate and understand that the best place to start when you're doing your groceries is on the perimeters, is what, that's where everything that you really need in order to be healthy, and also having group exercise classes. So a couple of updates on some progress that we've made on existing initiatives. There's the single entry point that's part of the 211 system. And so this is a clinical intervention, so those that are diagnosed with type 2 diabetes are able to be better connected to what to do about it, because a lot of diabetes has to do, managing type 2, it's really about making some really heavy lifting adjustments in one's eating and then also one's physical activity level. Through the 211, they're able to actually get some right size fit. We had a lot of ambitions on what this would look like last year, and so we do need to, I think we need support, so that there has been some feedback that clinicians, they don't know quite how to start that conversation to actually say, hey, I need you to call 211. And then we also need to ensure that on the 211 side, we have a little bit more robust options that are available to those that are diagnosed. One of the things that we're really proud of are the pop-up markets. They need a little more life. The pop-up markets are in their 5th year now, and there's been a great example of the shallow market, which is now almost entirely sustained by volunteers. And so we've got lots of opportunities in the other markets. And so what we realize is that before we really fade out, we've got to really invest in some capacity and agency development of those community members. So they need training. One of the first places we started was doing the Serve Safe, which is safe handling, so that those residents that are running those community pop-up markets can at least know, at a bare minimum, sanitary management of produce that's there. But on another level, this coming year, we really want to partner with ASAP and with RAFI, which is the Rural Advancement Foundation International, who has had great successes towards the east of the state on having these food systems conversations, but through an equity lens. So whether it's training more farmers market managers, specifically on everything from maybe having an EBT machine or ensuring that they can actually do all of the connecting with Manna Food Bank to ensure arrival, delivery, and storage is managed. We really want to make sure that the community is well positioned and has that capacity development training, because we know that this is a high stakes pivot that we want to make, and that they need a high level of engagement and support from us, so that there isn't any kind of trauma because there's been an exit from a heavy HHS presence. Something that's new is the Faithful Families program. And Faithful Families, similarly to the Praise initiative that ABIPA has been leading, works with congregations around implementing environmental as well as policy changes around eating better and also moving more. So the congregations that are participating in the Faithful Families cohort are the Tridestone Baptist Church as well as Bethel Seventh-day Adventist. And so together, the YMCA along with ABIPA will help create new policy shifts at these two congregations. I'm not sure if any of you all are familiar with Tridestone Baptist Church, but when they came on to do the orientation with us for Faithful Families, they brought us their health ministry calendar, and we weren't quite sure what we were looking at, but we thought, oh, is this the Buncombe County, or the Asheville City Rec calendar? No, this was actually the Tridestone calendar, so it's really impressive, and so we have a lot to learn from them, but we're excited about the pilot, and really what we intentionally align a high-performing church like Tridestone with one that has some interest, but really Tridestone will function as a mentor to Bethel. And so we're hoping that maybe next year or in the second round or iteration of Faithful Families, we'll be able to try 2 more or maybe 4 congregations, and then they'll continue to, as alums of the programming, be able to be a mentor or some kind of peer support to another congregation. What's really key, again, when it comes to all of these behavioral adjustments, is being able to have peer support, having accountability allies, having someone that can meet you for a meal or meet you at the gym. It all makes the difference in whether or not you're here. So now, infant mortality, and I'll let
Yes, I do, yeah. So just
that percentages of
I was going to point out that percentage is shown up again, and that's incorrect. It really should just be a 3.4 difference. And one of the things that I want to talk about is how deceptive data can be. And so I don't know if many of you are aware of at the national level, we have the Healthy People 2020. At the national level, we set goals every 10 years. And so there's a group together trying to set Healthy People 2030. They looked at the national level, like we made our targets on infant mortality. The truth is that's across all populations. And similar, if you look at Buncombe County and the state of North Carolina, it would seem that way. However, when you start to begin to actually take a look at the information that's available to us about race and ethnicity, 3 black babies compared to 1 white baby die every year, you know, in this, not the number, but the 3 times more likely. And I think the other piece of this is the, you know, in some ways, one baby death is something to really be concerned about. But, you know, I will say on some level, the number of infants that die every year is relatively small. And so that makes it even more difficult to be able to say how well are we doing, because all it takes is a difference in one to really skew the results. So we're looking at the 5-year trend over time just to kind of understand what the total picture is. And one of the significant reasons why the CHIP program was redesigned and we focused in from 6 priorities into diabetes and infant mortality was because of the trend that you're seeing from 2013 on, is that we're actually going in the wrong direction. And so we wanted to be able to refocus so that we can maybe. And so we're really lucky to have our community over, like, I think this is how many numbers, like 17 community partners who are active. And again, just want to reference this new way of doing CHIP is rather than having Deanna Lamont or Terry March show up to bring all these folks together and essentially look like they're leading, we have identified the YWCA, and it's on here as Community-Centered Health Home, but now it's called Mothering Asheville, recently changed its name, and that is a community-driven collaborative or coalition that's funded by Blue Cross Blue Shield. Both of those organizations are doing amazing work. And just 2 really quick stories about this new way of doing things. After the first meeting in which BIPA and YMCA leadership came to the table, and we're actually, it was clear to them that we're stepping back. We really want you to lead. The immediate response was, after that one meeting, it was remarkable that we just rolled up our sleeves. We said we're going to just talk about what we need to talk about, and we saw more get accomplished as a result of that than we've seen in a while. So I think that it's just, I just want to point that it's really exciting. And similarly, YWCA is a member of the steering committee for Mothering Asheville, but as part of the conversation, how are we going to do this work together and not have more meetings? There was a discussion about having the YWCA join the Mothering Asheville board, and that prompted a whole conversation about actually, and why not have Mothering Asheville get more engaged with YW as well. And so that creates opportunities for sustainability that, again, it's not about what we did, it's about getting out of the way to let the organic, authentic, strengths that are out there happen. So to me, it's really exciting to see that. And I will point out that the action plans that we have, again, is the application of results-based accountability, which is being able to try to provide for the work groups who are doing the work data, to help monitor and kind of take a quality improvement approach. And then the Mother Love program. So one of the reasons why the YWCA was elevated, I think in part because we know that, first of all, the mission of the YWCA in terms of eliminating racism is really significant, and we know infant mortality, really structural racism is probably the key driver of infant mortality among African American women. I've been known to say it doesn't matter Oprah Winfrey compared to a white woman of her same economics and her same education has 3 times, or in the nation it's actually more. So there's something about being African American in our culture that the toxic stress related to that plays a part. But the Mother Love program, so we, in the county health rankings, we saw a decrease in teen pregnancy rate. Teen pregnancy is a key driver of infant mortality, and part of it, it also linked to that is traditionally teen moms often have a higher rate of preterm birth, and preterm birth is a key driver of infant mortality. So this program has been remarkably successful at providing coaching and services to young pregnant moms, teens. And so some of this, I just want to give you 3 success rates from this program that are really remarkable. 90% of the participants in that program actually either graduated or moved to the next level, next grade level. So the success related to that, 83% of the babies born were born full term, which is really significant. And then there's also an interlinking between what's going on with Mothering Asheville. The core group in Mothering Asheville is Sisters Caring for Sisters, which is community doulas. And so 6 of the women, young girls, teens, a part of the Mother Love program were attended by doulas from Mothering Asheville. So again, just lots of ways in which there's a lot of community crossover and connection that's happening.
Good question.
Yeah.
Do the cap and gowns imply high school graduation or some other kind of?
Yeah, so
high school?
that 90% of the participants of the program either graduated or went from 11th to 12th grade. So that's kind of speaks, so that's what that does imply, yes. Not college, but high school. And then, of course, work that's happening here in the county. So there's a lot of effort among the community engagement team and to promote safe sleep. And then the Mother in Asheville has the really fundamentally, I don't know how many of you know what happened. There was a Blue Cross funded 2 years of just learning and developing a coalition. And the members, the coalition members that are part of Mother in Asheville went to Piscataway and Emma and just listened. And out of that, let the community, the women in the community, drive what the need was. Unfortunately, when it came time to do the next round of funding, Blue Cross said you have to pick one. We can't continue to work with both communities, which is a very awkward place to be in. And ended up moving forward, working with Piscataway, and so it was identified by the women living in Piscataway, the desire to build our capacity to support our community in the way our community needs to be supported. And so the Sisters Caring for Sisters in the training and certification as doulas, but also lay health workers. They're also lay health workers in terms of now they have tobacco cessation specialties certification, where they're actually helping to engage their community members in tobacco cessation. And then they have a peer group that meets on a regular basis and just supports. So there's a lot, I think, that we're going to be learning about the impact of that over time.
Don't they also have doulas?
Mm-hmm. That's the Sisters Caring for Sisters.
Okay.
Yeah, sorry. But yeah. And then the other piece, a couple other things I want to speak to has to do with really innovative thing that's happening at MAHEC, which is we now have an embedded fiscal legal lawyer, and through screening patients, so housing instability is yet another social determinants of health that's a big stressor that is implicated in infant mortality. So to be able to screen and kind of address the fact that someone has a housing issue and have them immediately go and sit with a fiscal legal lawyer who can help address those. So that's something that we're piloting. Then also the bringing together of all of the nurse visit partnerships, and that's what's happening with the YWCA. This is a nationally proven evidence-based intervention, is when you provide women who are at risk with home visits from nurses, they have much better outcomes and their babies live and more than, thrive. And then I think the through lines. So again, regardless of what we're working on for community health improvement, if we're not addressing health equity, we're not doing the work. And so that is going to just keep showing up as a core piece of work that we're doing. And then also ACEs. So the whole idea of adverse childhood events and trauma, both health equity and ACEs are tightly linked, but it's important to also be providing a lot more focus on the ability to train up and give those skills to anyone who needs them. And the thing that's really exciting about the adverse childhood event is they're beginning to see community resiliency model as one of potential evidence or evidence-informed trauma-informed practices. And those are tools that actually you can train individuals. Every one of us in this room could go to a 2-day training, just apply it to our lives, and it could make significance. And so there's a lot of effort in our community at engaging through the Speakers Bureau, again, community members who can use these skills, get trained in these skills, and then really get committed to how to use them and spread them. And the intimate partner prevention. So there was, we did not submit action plans for intimate partner violence prevention in 2016. I will say we see this as yet another through line. So if we're going to be addressing community health, we need to be looking at the role that violence plays and intimate partner violence plays. And so we are, every chance we have, promoting the Family Justice Center as evidence of the resources that are there and that are available.
And then I think that we also are seeing, as a result of the work at the Family Justice Center, an increase in screening. At MAHEC, we've actually had significant involvement in both across our family practice, family medicine practice and our OB practice in implementing much more targeted and effective intimate partner violence screening. There are 20 community partners that are totally engaged in helping to make a difference. And then I think it's really important to raise up that there was something, I'm trying to take a look at the numbers here, 41% increase in intakes over a one-year period since the Family Justice Center opened fall of 2016, which is significant, and that it's already being spread as a model for how to do this work. And so what we do is a collective impact model. We use RVA as a framework, which is quality improvement, but the idea that you bring partners together to actually work together to achieve the outcomes that we want. And I think the Family Justice Center is a really excellent example of what can happen when you do a collective impact approach.
So I'm going to share with you a couple of ways that through the Family Justice Center's really uplifting and driving of the efforts to move prevention from within IPV, ways that we're really seeing some progress. To begin, there's the public awareness campaign that many of you have seen possibly in these dark silhouettes, and it's part of the Still Standing. This is a way for us to be reminded that among us there are survivors, whether that we can connect, but also to really be able to help drive the issue and the awareness and the sensitivities, because one of the greatest ills and consequences is the social isolation that comes from folks that are experiencing intimate partner violence, and to help cut through some of the shame and ensure that there is that community level of support. There's also, as Evan had mentioned, the 8 primary care clinics that are now screening for IPV. Within the 6 months of really of having a targeted outreach at the clinical environment, there's over 500 women that were screened, and about 32% of them actually screened as positive for experiencing intimate partner violence. Helpmate's also been working pretty diligently and has been really committed to expanding youth awareness around IPV. And in 2017, they were able to train, or at least conduct some introduction workshops around IPV, and 4,000 teens within our area were able to learn more about IPV. That's from last year, just only about 400, so it's amazing how much of a concerted effort they're making in that connection to schools, as we know that a lot of those habits are started at a young age, and so if we can change that dynamic from early on, we can hopefully change the way our culture approaches relationships, and also what's considered acceptable as social norms in violence. That's the last slide, so thank you all. We can open up to questions or discussion. I'm not sure what we have in terms of our timing.
Any questions from the
So you all are probably doing this concerning infant mortality, but I was thinking about, since our denominators are essentially pretty low for infant mortality, are you all putting just as much emphasis on the low birth weights and very low birth weights, which are major contributors? Are you all also showing that data as the numbers are larger?
On the scorecard, and we're actually looking at that by grades as well, so we can see the differences. And so I think maybe Dr. Holder, you want to speak to the child mortality task force, what you discovered, or you want me to summarize that?
I mean, again, so all this is intertwined. Sometimes it's hard to remember what meeting I was in where this was discussed. But, so I'm the current chair of the Buncombe County Child Fatality Prevention Team. And so we review all deaths. And we started last year, right? when we were reviewing 2016 fatalities, we started internally kind of tracking the major, like what was the cause of death and what were the risks associated with that. So we have more easily, I guess, accessible data that we can sort of see what's going on. We don't really get down into the birth weights, but we are tracking prematurity. That's something we could add to it potentially. We can do with it what we want since it's an internally built system. Looking at Rob, we can start helps divide it. So that's a good point that maybe we could add that to it.
And really, we're looking at 6 core outcome measures. One is the infant mortality rates broken out just overall, and then healthcare disparity related to that, preterm, and then preterm birth as well as birth weight. So and also split out by disparity. So knowing that there are also a lot of things that we want to be measuring that can help us impact. So that's kind of what we're doing.
It's also a key indicator in our nurse family partnership program as well.
Okay, so is that would that be a part of the SOTS report, or how would we be?
And so we have actually the scorecard that's set up to support, so for each of the priorities, we have a clear impact scorecard where we're tracking measures. So on that scorecard, it might be good to be able to send out
Yeah.
the.
We see that as members of the CHIP advisory, but I don't think the full board has ever
Have access to them.
granted a view of that to see what that is, and there's a lot of data in there. So be careful, you can go down the data rabbit hole if you start looking at all the indicators. But it really is helpful in terms of seeing, well, where is information coming in, and then what's happening over time. And it does it in a really interesting way, in that it's just like a stoplight, red, yellow, green type of thing. So really kind of easy at a glance. I think it would be really beneficial, especially for board members who have an interest, to just have access to be able to see that.
And I will say that we also are, that is one of the biggest barriers we have to doing community health improvement work, is just in talking about the fact that what we were presenting today is 2016 data, and here we are in 2018. So even though we've got the data, there's still a lot that's missing in terms of really being able to know what is it that could actually make a difference. Are we really making a difference? And so I just want to be really explicit about the fact that somebody who's been doing quality improvement for 8 years, when you get really good data tools in the hands of people that are impassioned to do the change, that's all you need to do. And what we need to make sure that we get better data so that we can actually, be able to create that common language.
So that's why Rachel Long is really an exciting addition to our team, because we have someone that can really get whether it's the baby book, which is this, the state workbook on all of the births, and also down to the county level, to be able to just help us see all those nuances.
And the vision that we have and that we're beginning to put in place, and it's really fundamentally a trust-building piece of work, so it's going to take time, is for all the community partners where they can, is to share the data with us, that will then Rachel can use from an epidemiological support approach, be able to then see analytically what's statistically significant or what's even speaking to us that we're not seeing elsewhere. So we're just beginning to step into that. Right now we've got a deep conversation around that with FIPA, physical legal, YMCA, but it's slow. And it's historically slow across the nation, these kinds of conversations.
The difference I see from past years, you've made a very integral part or purpose to the CHIP work of refocusing it to include more community members, more peer mentors, so building capacity so that it's not just several controlling organizations, but it's becoming a grassroots effort to improve the health of everyone. So.
And I just want to report again our first meeting with YWCA leadership and Mother and Asheville leadership. Marcia Davis spoke about, and I think she named it correctly, is that I'm hearing that the traditional power structure is coming to the table saying we want to actually live, we want to support you in doing the work, and the trick is going to be to really walk that. And shared power is something that we're all going to learn from that as well.
But it takes you all to make sure that they're holding hands and moving forward.
Absolutely.
Thank you. Very important information today.
Thank you. And just one point to that, to echo your observation, we are now also embracing the collective impact, and they have a 3.0. And so 3.0, as far as where we are, the last version would have said that really what our function would be to be a high-performing management, but the pivot now is to move to movement building, and so that we're hoping that we're doing that by really trying to connect the community and support their agency in all of this.
And I know that you want me to move on. I just want to say one last thing, which is Zobu needs to be identified as an incredible asset to this work. She has come at it from a complete, like she's not coming back at it from a public health perspective. And it's not formalized in writing, but she heard back from the SOX report that was submitted to the state. The nurse who reviewed them across the state raised up Buncombe counties and said this will become the standard for all SOX reports in the future.
Yeah. And if any of you would like to attend a CHIP meeting, you have the lead chipper right here.
We will be sending out the SOX report. It's part of the next step. Once it's now been approved, then it goes out public, so all of you will get a copy of that.
All right, Rob, let's talk finances.
These up here. So thank you all for letting me come and present to you our financials. I know we was Jen at the meetings, and I'm happy to step in and fill that role. And as we go forward, if there's any level of detail you'd like to see differently, or any ideas on what you'd like to see going forward, I know we're planning on presenting our FY19 budget proposal at one of the upcoming meetings, probably May. It'll get a little bit of a deeper dive into the budget. So after you see that, you may have some ideas sparked there on maybe what you want to see out of the financials going forward. I'm going to present in a fairly similar format, and you will have your expenditure dashboard handout or printout in your packet, but you can also view it on the board intranet site as well as in a few different views. So looking at, as you know, the HHS budget is primarily made up of DSS and public health, the Department of Social Services. So as you can see, we are 67% through the fiscal year. And that we've kind of considered that to be our target, although there are a few exceptions to that. We are overall with DSS, we're at 53 or 55% spending, and you can see that by area, and you see that low bar on the graph there is our human services assistance dollars, and I'll explain why you see such a low percentage there, and you can see that broken out in the next. I know this isn't it's come out to be kind of hard to see here, so I apologize. And I'll go through what those are. So when you look at it by accounting unit, the area that you see way below the line is public assistance. What that is the state has taken over direct payments to child care subsidy recipient providers. So whereas we used to act as kind of pass-through for that money, it was upwards of $8 million plus Smart Start, close to $9 to $10 million that used to pass through our budget, no longer passes through our budget. It's paid directly by the state. We didn't know when that would actually be implemented, so we budgeted for the full year for those expenditures. Similarly, with the non-emergency Medicaid transportation, we partner with Land of Sky to administer, and the state took over direct payments to those transportation providers, with the exception of client reimbursement for mileage and disability transportation services, which was a small part of those payments. So when you actually factor that in, you can see that human services assistance, the third bar from the left in the graph, it's very much on target when you remove the budgets that we knew we weren't going to spend the pass-through money. So overall, when you look at it without those dollars in it, we are actually looking to be at 64% spending through 67% of the fiscal year. Looking at public health, we're similarly on target with 67% through the fiscal year and at 65% spending overall. Some places you see that we are at target or right over. We have some payouts for early retirees that happen that are one-time payouts that we won't see later in the fiscal year that kind of can increase the spending. But all in all, we are very on target for spending, and when you look at the revenues as well, factored in that we were coming in, the last projections that we went through were coming in close to around 97% on the fiscal year, so very on target. And when you look at it by accounting unit, you'll see the same thing. With some of the we contract with Mayheck for school nursing, you see that looks above target, but it's really just about the payouts for the contract, so we're on target to spend that budget. Cool.
Questions for Rob?
There's one last thing that's been added to the agenda that I'd like to talk about just really quick, and that is Access Buncombe. So in the past few years, we've had a growth of external sites that are permissioned, so that allow community members that don't have access to the Buncombe County network as employees to access a collaborative site, such as the board site. As part of that, we call it the HHS portal. That's grown in a lot of areas around not just HHS, but around the county, and the county has instituted a different way to handle those permissions. It's called Access Buncombe, and we've taken all of the emails for all the board members as well as our community partners and uploaded them into a system. And so if the email that you've provided us is the email you want to continue to use to log in to those sites, you're going to be receiving an email after this meeting with how to set up a password. It will be a password that will expire periodically, but if you expand your role with the county and start partnering on something else, we'll be able to easily use your account and just add it to different things. And so you'll be getting an email with instructions on how to set up that password to the email address we had on for you here after this meeting, and it'll just have you go in, set up a password, and then we can manage it from there ongoing. If you have any questions about that, feel free to email me or you'll receive, or Meredith Benjamin, you'll receive the email from.
We can do that. Thank you.
Thank you.
Philip, we had an opportunity, many of us, to see the ribbon cutting for the new building, and what a wonderful place for our clients and our staff and community. Tell us how it's.
Right, yeah, just kind of a quick follow-up from last meeting with the new building. All the staff, the economic services staff have moved into the new building, so the renovation of Cox is now begun. We're looking forward to having Dr. Mullendor and the clinical staff back into Cox, hopefully by year end. They are hoping.
I heard January, February.
They're tearing out walls pretty quickly.
I've
seen the little carts flowing out every day. So the renovations of Cox have begun, and that will allow the clinical staff and WIC to move back into the building, which, you know, it's been hard over the last couple of years not having it in the building. After you've had it there, and people get used to that kind of one-stop shop kind of thing, and they're able to come into the building and access many services and not having there and having to send people across town or whatever. So we'll be glad to have them back. So a couple of questions that came up around cost. I do have some figures, the actual budgeted costs for the building, the parking deck, the renovations to Cox's was in the neighborhood of $48.4 million. As of right now, certainly under budget, sitting at $41.3 million being spent with some encumbrances on top of that. So right now, actually sitting at about 91%. There's some dollars still sitting within that budget for the renovation of Cox and such. The other question I think has come up at times about why is my staff, the economic services staff, and the new building and health going back into Cox. What I will say, some of that's driven by dollars. There are dollars, revenue sources for buildings that are occupied by departments of social services staff and not health department staff. And ultimately, that's, at the end of the day, that's why the economic services staff moved into the newer portion of the building. but health will also gain some space this time. They were crammed into the first floor when we were integrated before, and now they'll have the first floor and the ground floor piece of that. So, any other questions about the building?
Okay. Just want to give you guys an update. When I first came on board, you guys advised me or encouraged me to get out in the community as fast as I could, as often as I could. And I want you to know I've been working diligently on that. The day seems to be in my way on that. But since we've met before, I've had the opportunity to go and visit Winches and spend some time there. And took me there, and that was a wonderful visit. I've also met with the superintendent of Asheville City Schools, and thanks to Suzanne, I've been able to meet with student services rep from Buncombe County Schools, and we've had some great dialogue around partnership there. I've been to the Vulnerable Care Task Force and got to meet the folks that are on there, which flowed really nicely in the safety net group. And we've also, with Chris's help, had 3 meet and greets, so now have a chance to really get around to all of our staff, which is difficult in a county this size, in addition to one staff meeting. So thank you for encouraging me to do that. It's been a lot of fun. Continue to work my way through community organizations. We have a lot. Also, just wanted to say we did have, well, first I want to make a great announcement. So I think when you guys approved my appointment in December, when I was reading the minutes, we had several key vacancies on the senior leadership team in Health and Human Services. So really, about that time, my position was vacant, Jennifer Chilton's position was vacant, and Tammy's position was vacant. So we had some pretty key vacancies, and I'm pleased to announce, well, I'm pleased to thank you for hiring me to fill one of them. And then last month, I announced Rob Moore to be our business director. And this month, I want to announce that Rebecca Smith has been hired as our social work director. So she'll be official on Monday. So she takes over Monday in that role. And now our senior leadership team is complete.
Yeah, the team.
We have
Fantastic.
move forward. I did also want to announce a couple of proclamations. Well, I'm going to announce one and turn it over to Suzanne. But April is Child Abuse Prevention Month, and we won't actually do a formal proclamation or approve it in this board until next month, because the commissioners will be making a formal proclamation in April, and that'll be at the April 17th meeting. If any of you guys can come to that meeting, I would invite you to, because not only will they be making a formal proclamation about child abuse prevention, Dr. Mullendorf will be doing her annual presentation on community child protection team and child fatality prevention team. So that the flavor of that meeting will be very HHS and very much around child abuse and neglect. So I want to make you guys aware of that, and then I will turn it over to you for a formal.
Well, it goes hand in hand with our talking about community health. So Chairman Newman has proclaimed as Public Health Month, whereas we hereby recognize and acknowledge 138 years of public health service for the residents of Buncombe County and all of North Carolina, and the immeasurable contribution of these services to safety and quality of life in our county, state. And whereas public health measures to control and eliminate infectious diseases, improve environmental sanitation, and promote healthy lifestyle practices have been the greatest cause of improved health status and increased life expectancy for Buncombe County and all of North Carolina residents. And whereas public health plays a critical role in eliminating health inequalities and preventing chronic disease and injuries, resulting in improved productivity and decreased healthcare costs for the Buncombe County residents. And whereas across North Carolina, a continued focus on prevention has resulted in a 40% decline in heart disease death rate since 2000, a 45% decline in age-adjusted stroke deaths since 2000, and a 56% decline in birth rates for teens aged 15 through 19. And whereas Buncombe County is committed to a continued emphasis on prevention and public health and on helping North Carolina reach a better state of health through activities outlined in the North Carolina 2020 objective. And whereas our communities work together to develop innovative solutions to health problems facing the people of Buncombe County and North Carolina. So therefore it be proclaimed by the Board of Commissioners for the County of Buncombe as the month of April 2018 proclaimed as Public Health Month. So thank you all for your work in leading that and sharing that information with us, not only what happened to set that baseline of 2016 data, but all the action steps that you're taking to improve the lives of our citizens. And the only thing I was going to add, Dr. Mullendorf led with Dr. Mims a wonderful shelter protection focus group that many of us attended. And we are still working toward building the immunization rate of Buncombe County that affects our public health. So we'll continue. We had great dialogue and great suggestions shared. So good work being done in the community. So thank you all for being here and for your voices in the community to take this information forward, and let's not keep it a secret. Nice to see you, Lucy, and Dr. McLean, welcome. Good to see you. Meeting adjourned.
Thank you.